Thank you again for the opportunity. I'm gonna go over, maybe this is the last talk of the day, but I'm gonna share with you the experience with combining two robotic at the same time, robotic from bronchoscopy point of view and Da Vinci XI, to see how we can get better answers and better resection with small lung tissue. So I have only disclosure with the intuitive, but the talk today will cover number one, how we do the marking, and what is the literature available about marking in general. And the second thing is we'll focus on the percutaneous versus the endobronchial, and then I will share with you the experience that we had with the new part of innovation of putting the fiducial coil that we'll cover today. So marking of the tumors in the past for the surgeons to be able to perform segmentectomy done in different ways, but done before by using either the hook wire from transcutaneous, and then they open the patient to see where the segment and remove it, or by using regular fiducials from Medtronic or coils even transcutaneously, and also use by injection different types of dye, either the ICG or the barium and methylene blue. But unfortunately, as we know, even with biopsies in general, we have the same problem with fiducial marking transcutaneously. And what happened is you can see the pneumothorax in all the literature shows that it's high, from 3% to 60%. The risk of hemorrhage or bleeding in the lung also was high, from 2 to 41. The upper numbers that you see, 60 and 40%, are more with really using the hook wire that we saw, less with the fiducials and less with the dye, although those were also happened in those cases. And dislodgement and loss of the fiducial also happened with those. Then the surgeon goes in and the fiducial sitting in somewhere else, or the injection didn't happen. On the other hand, with the injections of methylene blue or ICG, there was the complication with endobronchially was limited. So there was no much pneumothorax or hemorrhage when endobronchially we approached that by using either navigation system or the bronchus itself. However, the chances of having successful labeling or marking of the segment was lower. And you can see that in some of those cases that either the signal lost because after injection, the ICG went maybe intravascular and went somewhere else and did not stay in the tissue, or when they inject also, it went all over the pleura, and now it's more confusing than helping, because we are looking always to see this signal, which is the type of localizing the lesion to help to know exactly where to remove. On another literature for SBRT, there was the kind of use of those type of coils. And the coils that you see here used usually for thromboembolic effect inside the bronchial arteries for hemoptysis cases. However, the idea of having those feathers around the coils, which is this one in this study used the Boston Scientific 1 by 5 millimeter, and used, as you see, also the cytology brush to load the coil inside it. Those were done 10 years in 2010 and placed on the nodule for the purpose of having SBRT done for the case. With those done before, you can see how they look on the CAT scan and the X-rays, and also the placement done by using the navigation system. The risk with that technique, because I think the coils has to push out, you have to push out the coil, especially if you are in the pleura, there was some risk of pneumothorax of 5.3. And the goal was to do SBRT, not segment removal. So it was more radiographic labeling more than a visual labeling. All what we need to see that coil on the X-ray and easier to apply the radiation. So now combining those two ideas together to see if we can get localization of that lesion by using the ICG mixed with the fiducial, that's what the next step is. This is a case that done last month, and you can see the patient has already diagnosis of right upper lobe lung nodule that has ground glass opacity. And the advantage here, the nodule is next to the pleura, as you see. So this case prepared in the morning that have the ion and the XI in the same room. The sterility and the equipment for the XI stays in this side. The equipment for the labeling with the using the ion on the side that can leave the room after we get the label done. We use the O-arm for that to have accuracy for placement of the tool in the lesion and the fiducial in the lesion. And the O-arm, as you see, it needs a lot of space, but come as a C and then close up to achieve the full circle around the patient. And then from there, we can do the spin. The spin is included inside, so you don't have to free after you get everything aligned in this situation like that. And it takes, when we spin, 13 seconds usually for the spin. This is after we started the case, and you can see the ion, and we have the catheter in the lesion there. After the spin, we confirm that we are in the area. After that, we use the Medtronic deploying device by using also the coil from Cook. In this case, we use 7 pi times 3 millimeter. The ICG mixed. After mixing the ICG and putting it together, we were able to flood the coil with the ICG to make it soaked, so that kind of fibers become soaked with the green, and then uploaded into the deploying system by pushing the fiducial marking into it. This is a picture of a coil that already soaked with ICG, and you can see the signal of the dye already really saturated on that coil. Now, we are ready with the coil inside the catheter. We spin and we confirm that we reached the catheter after driving with the robot, as you saw earlier in the morning with multiple talks. When we reach the target and we make sure that we are on the target, then we proceed by deploying the coil. And you can see it's pushed by having the catheter out of the robot and then pushed through with the guide wire out, and the coil already sitting in the area where we want. Since this was our first case, we did another spin after having the coil in the area to confirm that we are really next to the target or on the target. And you can see from this coronal that the coil is sitting exactly where we want it. And on the sagittal, also, it has the same signal where we want it next to the ground glass opacity that we're looking to remove. After we place it, we use the same catheter to push 2 cc's of saline with air just to flood the whatever inside the coil to go toward the pleura, because that's where the signal we want to be catch when we put the firefly light inside the patient after proceeding with the lobectomy. And after putting the coil, you can see it blocking subsegmental area on the airway with the green material there. And now, after turning the patient, XI in, the ion left the room, the O-arm left the room, and now the surgery started. With the XI changing the light wave, you can see very clearly here that the lesion is very labeled in our area that the surgeon now doesn't need to really fish where it is, like in the past, try to get a feeling or see if the signal is there. So at that lesion really gave us the best signal with the starting these cases. And then you can see now, follow the ICG coming from the pulmonary artery right here and transfusing throughout the lung. This ICG injected after the subsegment perfusion already clamped and sutured. That gives the surgeon now an idea where is really the segment that is, in this case, the apical system, anterior segment that already blocked. And now you can see the signal from the ICG from labeling is different from the one that coming through the venous. This helped the surgeon a lot by now do some cautery signals on the lung to know where they should put the blade to start resection. And you can see by turning the lung anteriorly and posteriorly, you still have a clear signal from the fiducial marking. After doing that, it's now you have a line for the cut by that, and it's easier now to know exactly where your resection. And every time you change the light, you can see that you are inside the lesion still within the part you are resecting. And that good feedback gives smaller amount of tissue to be removed with more accuracy to have a free margins. This is the same pathology. As you see, the nodule is exactly under the pleura. And also, we got a free margins on that, in this area here, with a good 2 centimeter. You can see also the ICG, where we put exactly the coil. Also, the coil were also retrieved out after the surgery. But nothing is perfect in life. This is after we start that technique. We had some cases where the nodule was not that in the pleura, and we thought that we are good. If it's even central, we'll get the signal. But that's not the case. For example, in this scenario here, you can see the nodule is not exactly touching any side of the pleura on the coronal or the sagittal. And in this case, you want to guide the surgeon by creating a signal coming from any closest pleura. So even in the sagittal, you have at least 5 centimeters that way, 2 centimeters that way, and 3 centimeters apical. So whenever we face something like that, and we see that more than 2 centimeters, we had the chance now to learn that the best way to do the evaluation when we see anything with such a case, we try to create what we call a phantom or ghost signal, which is by the robot, we create another target that is beyond where the real nodule is to help placing the fiducial in that area closer to the pleura to help having the signal light up in that area. So for example, in this case, we might put the fiducial right here, or right here, but not on the lesion, because you have that depth in the tissue that will not give you the chance to get a good signal when you put the firefly. This is how we planned this case. So we know is the target here, but we created another target. And you know the iron always give us this anatomy borders by purple line, which is the pleura. This case, in those cases, we want to be closer to the pleura to put that fiducial. And you can see here, after we did the spin, we tried to put that fiducial in that area, and with placing it in that high up, we managed to get the signal in that area we wanted. Also, we achieved the same thing. Now you have the signal from the fiducial after suturing and clamping the segment perfusion artery. You can see the ICG perfusing the rest of the lung except the area that we resected. And that's the goal we were looking for. I think still this technique need some kind of modification, either by injecting more ICG, not using the fiducial only, or flushing it with more saline or air to give that signal to the pleura. So with that, I think as a conclusion from this, our goal from that technique is to see if we can minimize the amount of tissue removal that we can get with with the clear margins without removing lobectomy, and changing that lobectomies to be more segmentectomies in the future. More manipulation and use of different coils can be implemented. This is cases where you see the technology using the two robots at the same time, very helpful for better patient outcome. And we will see the outcome with more cases, especially we noticed improvement in the margins that we are clearing when we take out. Also, the length of stay of the patients after doing segmentectomy. Usually, you see them, especially in the upper lobes, leaving the hospital next day after surgery. With that, I will come to the end of this talk. And I can't do anything without the staff I work with. And please feel free to subscribe to the YouTube channel for any updated techniques and stuff that we're doing. Thank you so much.
Hi, AB, wonderful lecture, and here. I just have a question from here, on your left. So all these cases, what you showed are images from O-arm?
Yes.
Yeah?
Yes, those O-arm images.
And does O-arm has an augmented fluoroscopy?
Not augmented fluoroscopy, no. Okay. It's just the pictures that you see. Actually, it's just a spin, and then we analyze it. So we can see where the catheter in relationship with the nodule. And when we change to sagittal, and we change also to the coronal, and then we know if we are anterior, lateral, we are medial or posterior, if we are apical or more caudal. All of those we analyze, and then we change the catheter.
Okay, thank you.